So really, really delighted to be here. And the first thing we're going to talk about a little bit is looking at the issues around once a diagnosis has been made. But a little bit about my own background. I'm aware that many of us are here in a family role. Maybe we have a diagnosis, maybe we don't know, but we will be receiving a diagnosis at some point in the future. And I'm here in that unusual role of being a family member and a former carer and a professional. And looking around the issue of diagnosis for me has become particularly important over the last 5 years, in as much as an incorrect diagnosis was made. There were many misadventures, and my stepdad, who was diagnosed with Alzheimer's type dementia, in fact had Lewy body type dementia, and was given many, many increasing doses of psychotropic medications, which ended his life prematurely with the kidney failure that we hear is associated with that complex. And so getting an accurate diagnosis as soon as one is able may not be a person's immediate decision, because actually, what do we do then once we have that diagnosis, once we know? And for some people, knowledge is power. For some people, ignorance is bliss. And there's a whole range in between. And so in my role as a nurse, as a psychologist, as a therapist, as a family person, I've had the experience of hearing lots and lots of people's stories and experiences, as well as my own family's experiences. So looking at what diagnosis means is going to be as individual as there are people in this room and people on the planet. And so I guess from my perspective, it's really getting to know that one person and finding out what they want to know about their condition. I've certainly had people as clients in therapy who have received all of their assessments. GP has told them that they now have Alzheimer's disease. I know that about them, but when they come, they never talk about it. They're talking about my relationship with my partner, my grandkids, what I want for my future, how I want to stay in control of my life and do the things that I love. How can I keep doing that? And so it would not be my role then to say, yeah, but Mary, you've got Alzheimer's disease. According to Mary and her perception of herself, she's got something going on and she'd rather not talk about it. And so every person is different. And we sometimes talk about, well, if only that person could come to terms with it and accept it and not be in that place of denial, they'd be so much better off. But you know what? Denial is not just a river in Egypt. It serves a purpose. Denial is one of those ways in which I can cope with this huge thing that's going on in my life until I'm ready. So please don't anybody feel that if you're in that space where you're not quite coming to terms with what's happening to you or to your relative or your partner, that you've got to somehow get to that place. Just take a deep breath and take your time. You may get there and you may not. It's not for us to judge. It's for us to offer all the information that you can get and to be alongside you on that journey, supporting you. And I'm totally not even on my paper now. This is just off the top of my head. Now I'm going to talk about what I'm supposed to talk about. And I would really appreciate, Lisa, if you could wave madly at me about 5 minutes before I'm meant to stop, okay? Right, so we could talk about the medical approach and the scientific approach to diagnosis for months, couldn't we? Person after person coming up and talking about fabulous, interesting, wonderful research and things that are really changing. I'm not going to do that, sorry. But when I began working in this field, it was by accident, as some of you may also have had the experience, that you end up working with some particular group of people that you hadn't actually chosen to work with. I found myself having trained as a nurse and gone to back to university to do psychology. I was then living in the States where most of my family still live. I was doing a master's degree and doing 3 jobs, you know that kind of scenario. One of those was working in the community as a nurse with people with dementia. About 3 o'clock in the morning in a very, very cold New Hampshire winter, and believe me, the snow can be up to here, I was doing night duty for a person with dementia whose wife had gone to stay with her daughter to have some respite, and we had nurses round the clock. Suddenly, Bill, let's just call him Bill, decides he's going to go and find his dog, of course, with his pajamas and his bare feet out into the middle of the sub-zero temperatures in New Hampshire. So off he goes, and then I'm running after him, trying to find him, and he's very quick on his bare feet in the ice, whips around the next corner, finally found him. And it's the only time I've ever chosen to lie to a person with dementia, but it was either that or he was probably going to die of hypothermia. He was looking for his dog, Bingo, who he had when he was 12. And I said, I think the dog might be back at home, Bill. So we went back home. By the time Bill was counting his mini marshmallows to put them in his hot chocolate, the incident for him was forgotten. I was a complete wreck, as you can imagine. My heartbeat going a million miles an hour. I barricaded all the doors and windows, which of course we now know is not legal. But Bill was not going anywhere on my shift. But when I was sitting in the corner having hot chocolate with Bill, I was thinking, how does Bill's wife cope with this? And back then, in the early 1980s, having trained as a nurse and as a therapist, I knew nothing about dementia, apart from pre-senile, before you get old, or senile, you get it when you're old. That was all I really knew. Our approach was about the tasks of caring, not about understanding the world from within that experience. So I began a single-person quest, if you like, to find out as much as I could about what is this, what is the range of conditions, what is this that's affecting this family member as well as the person. One of my first publications was in 1986 in the Journal of Gerontological Social Work, which was looking at a project I did with a social work colleague on psychoeducational support groups for family members. How the hell do you cope with this thing? Based on Stephen Zaret's research around perceived caregiver burden. And I'm so thrilled to say, all these years later, Stephen Zaret's original research is still being used as indicators of how family members are coping. And all that time has gone on, and I have become even more passionately involved in this work. But it also means that as time has gone on, I've experienced that role from a family carer's perspective as well. I don't know why my mother ended up being a carer for someone with vascular dementia, and then for a second husband after that, someone with Lewy body type dementia. You'd think that one go round God would be enough, okay? But why that happened, I'm really not sure. But I personally learned many lessons, including how insignificant and hopeless it is when you're a professional and you're also a relative. And that was a very unusual experience for me to be in, and plus being 3,000 miles away on the phones to doctors, social workers, hospitals, all sorts. And it wasn't until after Robert had been dead probably 3 or 4 weeks that one of the psychiatrists said, oh, I guess it probably was Lewy body dementia and not Alzheimer's type, by which time it was much too late. Now, the good news is Alzheimer's Society, bless them, we've got representation here, has now come out and said to us, as if we didn't know, but life doesn't end when dementia begins. There are lots of things that are difficult and dreadful and sorrowful and very upsetting about living with dementia, but it's probably our 21st century challenge as human beings. And I met the lovely Mina earlier from Greece, and we were saying, actually, we all speak the same language. As human persons, we know what it feels like to lose our abilities, to lose our memory, to lose our loved ones who, even though they're physically with us, may not remember who we are. And how we connect together and how we create ways of being together around these conditions in the 21st century is really what's going to make the difference. So we can know a lot of information, we can know a lot of technical stuff about diagnosis. In the end, how do we carry on with our living? One client said to me, I want to carry on living my life to death, even though I now have dementia. He says, I might know the name of the thing that might end my life if I don't get hit by a bus and I don't have a heart attack. But until that day, I want to live my life to death. And so I've really become committed to how do we do that? How do we share information, but also as a therapist, how can I be alongside a family member or a person with dementia for people to explore how do we carry on living well? And I have to say, I'm maybe the only person on the planet who, when I saw the dementia strategy title, Living Well with Dementia, I laughed a lot and I said, you have got to be kidding. Did anybody else have that reaction? What I discovered afterwards was actually people with dementia have told me it's possible. And I want to end with a very short DVD clip of people with the diagnosis talking about their experiences, because I feel they can speak to this much better than I can. But actually, people can learn to live better. If not well, let's do it better. And for some people, it may never feel like it's actually living well with dementia, but maybe it's a little bit better than living alone or living without information or living without support. So I think it's a big ask, living well with dementia, but I think we can live better lives with dementia if we are working together and supporting each other. Some of the good news around diagnosis is that when I first started this work in the early 80s, getting it right, that means making a diagnosis and then matching that up with the condition of someone's brain after they had died, that was about 10% accurate. What do you think it might be today in terms of the accuracy? It's about 90% accurate, which is incredible. That speaks to a huge amount of development and research and all the many, many people behind those terms that carry on day after day in the lab, doing the assessments, doing the inventories, sitting in the libraries, doing the research. So we've come a long way in the sense that we are clearer about the condition in the person who's still living and then comparing that with the person once they have died. So some good news in a very, very easy to understand way. The other thing is that the brain itself, and I do a lot of teaching around the brain and dementia, is incredible. We know as much about the human brain as we know about the universe. So that means hardly anything, really. And we've learned, and we're learning so much more about the brain and its capacity to do things differently. One of the reasons I was so interested in doing the therapy work, the counseling work with people with dementia, is because generically speaking, we know that counseling and psychotherapy helps to create new neural pathways through the brain to help people think and behave in different ways. So if you're losing your neural pathways and your nerve cells because you have a degenerative condition like dementia, why wouldn't you want to do something that could help create others? So it's not just around counseling that we can develop new neural pathways, but about enriched experiences of living, about enriched experiences of relationships, of doing, of enjoying the simple pleasures of life. We can strengthen those nerve cells that still remain. We can't get the other ones back to life as far as current research goes, but we might in some cases around dementia. We can always just help one another to create the possibility that we're really giving that brain the best, the most it can possibly do. And so generically speaking, we say things like healthy living, all things in moderation, exercise, sleep, balanced nutrition, a spiritual practice of some kind that helps you to see outside of your own circumstances or your situation, whether that's faith-based or not. Lots of laughter, lots of friendships, and I probably would say lots of chocolate cake. But those sorts of things will help our brains continue to look after who we are. And that embodied cognition, you know, we are not just our brains, we're walking and we're involved with our environments, aren't we, in every capacity. So when we think about changes in cognition, let's not isolate that and think, well, it's only about the brain. It's the whole of who we are. And this body of ours walks that brain through our experiences. So we've come a long way in terms of diagnosis. And having that diagnosis as soon as one feels capable of being able to go through the process and support the person with it, gives us the opportunity to learn more, and therefore to understand more, and therefore to do more, and to be able to share more with one another. And I think in the therapy work that I've done, supporting people as they decide, how am I going to talk about my diagnosis with others? How am I going to talk about what I need with others, so that it doesn't become a barrier to our relationship, how it becomes a way of sharing in that relationship. And I remember a woman in therapy who was finding it really difficult to get the words out at the right time, and the correct words in a given conversation. And it would make her really upset and really anxious, and so then she would stop wanting to have the conversation because it made her feel embarrassed. So we talked about that in the counselling session, and we decided that what she wanted to do was to let people know what was happening in the moment, so she didn't get embarrassed and then shut up because she didn't want to talk. So we went with this idea called go with the flow. And she wrote it down on a piece of paper, go with the flow, put it in her handbag. And whenever she was stuck for words, having word-finding difficulty or not being able to get the words out in time, she'd pull out her little piece of paper and she'd read it out loud, go with the flow. And of course, now that creates an opportunity to have a conversation about what that means. Rather than her getting stuck and having the problem, now we can talk about why I find it hard. So you might need to be more patient, or maybe you need to use words that aren't so complicated. And so going with the flow then became her kind of mantra to talk about what's going on with me since I've had this diagnosis. So it's just about communicating with each other. What's going to work, what will be helpful, what really irritates you, what drives you around the bend. But unless we have the conversation, I might be making assumptions about you and what you need, whether that's you as a carer or you as a person with dementia, and I might be getting it all wrong. Let's just have those conversations. So I'm not going to assume that you don't know about the different types of dementia. If you went to the Queen Square Hospital for Neurology in London, there would be specialists there who would tell you there are probably around 100 or so different types of dementia, very specialized types. We know maybe about 12 that we might come into contact with, but mostly we know kind of about 3 or 4, don't we? So what would be the most common form of dementia that we hear about and that we know about from reporting? Alzheimer's type dementia, and even within that category there are lots of different subcategories of Alzheimer's type dementia. What might be the other 2 big ones that we talk about a lot? Vascular type dementia and dementia with Lewy bodies or Lewy body dementia. Interestingly, we've known about them all for a very long time, haven't we? It seems like it was 20 years ago, but Alois Alzheimer talked about Alzheimer's disease in 1907, and then Friedrich Levy, or Lewy, talked about Lewy body type dementia in 1913. We hear about sometimes Pick's disease, which is a fairly rare form, often of young onset dementia, but Arnold Pick, who named the condition after himself, was a colleague of Alzheimer and Lewy. And if you go to Munich, you can go to the laboratory where these guys actually worked alongside each other, examining brain tissue and looking for clues to determine what were the kinds of things that were causing the problems with the patients they were seeing. But at that time, the degenerative neurology of older people was not very sexy. Freud was around, and so you can imagine everybody was quite interested in what he was saying. So this kind of neurology was left for a long, long time, unattended. And we've only sort of seen the resurgence as we're all living longer and we have better access to assessment and diagnosis. So the brain is the organ that's under attack, if you like. And so we want to be paying particular attention that when we're looking for diagnosis, there are also a number of other conditions that have nothing to do with degeneration of the brain, but have to do with an assault of the brain either through trauma or through tumor. And the person is going to suffer and experience particular changes to their abilities with their brain, but they're not necessarily going to die from them. So we need neurologists to be involved in that process of assessment and diagnosis, the same as we do across the whole medical spectrum, because it could be that the condition is something that is a neurological difficulty. We also know that experiencing mental health issues, particularly depression, can create the beginnings of what looks like dementia, but is actually a clinical depression or a severe depression. But in the early stages of dementia, depression and dementia need to be ruled out as much as possible, and certainly where treatment is available, treating the person for the depression will help the dementia symptoms, if in fact it is dementia. Treating the dementia can help the depression. And you might be saying, how do we treat dementia? We treat dementia the way we have our relationships. We have some medications that are available, but the most important thing people tell me is that the form of treatment is who we are with each other, is how we respond to one another in caring and supportive ways. So when someone says to me, oh my gosh, it's Alzheimer's and there's no treatment, I say, hang on a minute, we've got lots and lots of treatment. Does that mean there'll be a cure? Not necessarily, but it means we can experience continuing to live with dementia, perhaps a little better than before, if not well, in order to support each other. So there's a lot of treatment available. And when we think about the experience of the brain, some of the most wonderful treatments and therapies and experiences are about focusing on what happens in the right side of the brain. People's ability to be creative, responsive, to enjoy music and singing and movement and dance, and to be able to paint and to be able to draw. All those sorts of experiences which the right side of the brain is very capable of can help create new associations and new abilities to communicate with each other. And for the person themselves to feel good about who they are, because actually it doesn't matter so much if you don't remember which day of the week it is, or you haven't got that in your diary quite the right way, or if you don't, excuse me, if you don't remember how to drive your car. As unfortunate and upsetting as those things are, when we take the focus away from the obvious concerns and deficits and focus on the residual strengths and abilities, we have a whole other conversation, we have a whole different experience. And I'm sure some of you in the room have had experiences of that yourselves. How's everybody doing? You all right so far? Okay. So finding that diagnosis is going to be important, and maybe for some people more than others. And it's not up to us to force that on anyone, but to create opportunities for information sharing and for knowledge gathering. So how we respond to that in terms of the appropriate resources is also hugely important. And we know that that's something that we want more of. We need more resources at our fingertips for all sorts of situations regarding dementia and care of people with dementia. But one of my favorite persons, who's no longer living, unfortunately, the late Tom Kitwood from the Bradford Dementia Group, gave us an incredible legacy of how to respond to and look at the lives of men and women who are living with dementia, whether as a carer, a family member, a professional, someone with a diagnosed condition. And for me, Tom Kitwood helps to identify ways that are fairly simple and straightforward from how I see them, that apply to me as the family carer, and they also apply to the person living with dementia. So if you forgive me, I'm just going to put a couple of things on the flip chart here. Many of you may be very well familiar with Kitwood and what he says, but in a gathering such as this, I feel it would just be useful to reiterate and perhaps re-emphasize the parts of Kitwood that are sort of universally applicable. And of course, Tom Kitwood has written many, many, many words about dementia, and I'm just taking a couple of things out that I have found useful and family members have said they've found useful. And the first one is it all right to walk over here? Kitwood's, what he calls the enriched model. Does anybody know what I mean by this? And I'm not very good at maths, and so when you put plus signs and equal signs anywhere, I always get a bit fidgety. But actually, if you take the time just to look at each of the ideas, it really makes sense. So Tom Kitwood says that dementia is a number of things. It's not just about the changes that occur with the individual nerve cells in the brain, although that's really crucial, and we want to know all that science and medicine can tell us about that. But he says that dementia is about the neurological impairment, what is happening to the brain, but not leaving it just there. It also involves the person's underlying health. And we heard already this morning that some people, of course, will have several health conditions, pre-existing perhaps before they have a diagnosis of dementia, or maybe they develop dementia and then they have other health problems that come along. They're all going to have an influence on each other. So dementia is about the neurology and also about the underlying health of the person. It's also about their biography. How I might experience my dementia is going to be related to who am I? Who have I been? What has been important in my life? Who's my family? What's my culture? What are my preferences? We do a lot of life story work that really enhances and supports the idea of looking at someone's biography. So a person's dementia experience will have to do, in part, with their biography. It also has to do with the personality. We're so individual, we're unique, aren't we, each of us? And how someone deals with their diagnosis of Alzheimer's disease or vascular disease, in part, will also be relevant concerning who they are, their personality. How have they dealt with things in their life? What are the things that are important to them in terms of how they have developed their sense of worth, their sense of self? And it's also going to be important how the individuals in the community, whether that's the family community, whether it's the Norwich community, whether it's the global community, how do those individuals have attitudes, beliefs, and behaviors that either help me to cope with my dementia diagnosis, or as I support my relative, or that how they create a barrier, how they don't help me at all. And Kitwood calls that the social psychology, that which is surrounding the person and the family. What are the attitudes and the beliefs? Because they're going to be very powerful. So I find that really helpful, that dementia is not just about the nerve cells and the brain changes and the cognitive change. It's about the whole of the person and bringing that holistic perspective into focus. The other thing that Kitwood does is he helps us with a visual impression of looking at the psychological needs of a person with dementia. And he does that, and some of you are very familiar with Kitwood's flower. He does that by giving us this idea that a flower with petals can represent these different aspects of social, the psychology for the person with dementia. And so you may have come across this before, but it's very simple and straightforward. He says one of those needs is the need for comfort. And you and I know that if we're not comfortable, whether we've got the wrong tights on, well, maybe not for the blokes, but, you know, the wrong shoes, we're sitting in a chair maybe like this that doesn't help our back, we're really thirsty or hungry, the temperature's wrong. If we're uncomfortable physically, emotionally, socially, spiritually, we're not going to have the best experience, are we? So looking for comfort, which is why we have lots of lovely tea and coffee and at least 5 different types of biscuits. That's all about helping people be comfortable and then using that social experience of tea and coffee and refreshments as a way to remove barriers and help us feel comfortable with each other. So comfort is going to be absolutely key in our experience of dementia, things that we really need. We all need to be included. You know how horrible it feels when we're not included, whether we have dementia or not, when we're feeling on the outside of a discussion, a conversation, a group, or our life. We know how awful that can feel. So inclusion, being included in this experience of living with dementia and what that means. Having things happen that are about my identity. the very unique person that I am, being able to have that experience of unique self supported and enhanced. Nonetheless, I may have a cognitive difficulty, but who am I and how can I remain the person that I am? He also talks about attachment, and by that he means being able to have attachments to good relationships, to pets, to people in your community. And sometimes some of the hardest things is for a family member who's caring and doing a really good job to actually let somebody else come in and give them a break. But you know what? Perhaps the person with dementia needs a break from me. Perhaps they need someone else in their environment to provide stimulation, a different conversation, a different way of looking at the world. So attachment then becomes what's important with your own family and your carer, but also about being able to make healthy attachments to other carers, to the lunch club, to the dementia cafe, a whole range of different sorts of relationships. And finally, he talks about occupation. And he doesn't mean, are you a milkman or were you a nurse? It means, what do you do that's meaningful? Now, what I might think is meaningful, and say to Lisa, this is what you need to do because this is meaningful, Lisa's going to be going, you've got to be joking. I don't think that's interesting. I don't want to do that thing that you're telling me about. So for it to be appropriate, it has to be intrinsically meaningful to the person in terms of what he or she wants to do. And when we find something that has a meaning to us, then we get the motivation to want to pursue that, even if it becomes difficult. Because we really like that thing, we really want to go to the beach for a walk, we really want to take the dog out. How can we find a way to do that that's going to be safe, that's going to be enjoyable? But don't make your meaning my meaning. Please help me find how I can do what I still think is important to occupy my time, to occupy my abilities. Okay? Now, unapologetically, in the center of this flower, Kitwood places the word love. And Tom Kitwood and Kathy Breeden, who started looking at the whole area of how do we support people with dementia, were trained in the good old person-centered way that Carl Rogers had established. And part of what Carl Rogers said was, we want to be accepting of all people, unconditionally. And Rogers has that as one of his core conditions, unconditional positive regard. But at the time, Carl Rogers was fighting all of the universities to show that actually counseling and therapy was scientific. And so using the words unconditional positive regard was much more appropriate and acceptable than using the word love. But before he died, Carl Rogers said, you know what? What I really actually meant about UPR was love. But by that time, he didn't need a university job, so it didn't matter. But Tom Kitwood, trained up in this approach, said, why reinvent the wheel? Let's look at the conditions around the person-centered approach, and let's look at love, how important love is as a psychological condition for the person with dementia. And of course, we know love can take on lots of different meanings, can't it? It doesn't necessarily have to be one type of love. It can be a whole range of different experiences that are about love. So Kitwood wrote this and demonstrated this with the flower for the person with dementia. When I look at that flower, I think, that's what I need. That's what I want in my life. I need all these things too. And what we've discovered is that we have more in common with the person who has a diagnosis than we don't. We have more in common than we don't. And here's that universal language around which we need to work and cluster together. We all need this. And if I have cognitive changes going on, how can I get this for myself, or how can someone help support me to receive these aspects of my psychological well-being? And if I'm that family carer, how do I have these for myself? And if I'm not comfortable, how can I help the person I support be comfortable? If I don't feel included in my own life, how can I help include that person in theirs? So all of these aspects are going to be really important for that family person providing support as much as they are, as Kitwood wrote them, for the person with dementia. Okay? Are those things that you can take away? Maybe you're using these ideas already, so they perhaps we're just sort of encouraging you to use them a bit more. Maybe they're new. But I wanted to give something that is not just about the statistics, that's not just things that you can find on the wonderful Alzheimer's Society website and many, many other places for information, but thinking about diagnosis and what do we do afterwards? How do we live with a diagnosis? Okay, I'm going to stop there.